Hello, and welcome to Grand Rounds for the Minnesota Regional Spinal Cord Injury Model Systems, or MNSCIMS for short. Thank you so much for joining us today. So, MNSCIMS is funded by the National Institute on Disability, Independent Living, and Rehab Research, or NIDLR, Spinal Cord Injury Model Systems Program. And the purpose of SCIMS is to support innovative projects and research in the delivery, demonstration, and evaluation of medical rehabilitation, vocational, and other services to meet the needs of people with spinal cord injury. Next slide, please. MnSCIMS represents an exciting partnership among the following institutions: Courage Kenny Rehab Institute in Minneapolis, Minnesota, Mayo Clinic in Rochester, Minnesota, Regions Hospital in St. Paul, Minnesota, and then the University of Minnesota in Minneapolis, Minnesota. Next slide. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical services, acute care services, acute rehab services, and post-acute services. My name is Dr. Angela Hanks, and I will be the moderator of today's session. I'm a research professional at the Department of Rehab Medicine at the University of Minnesota Medical School and co-investigator with the MnSCIMS. Next slide, please. A few housekeeping notes. The University of Minnesota has organized the CME for today's webinar. Please see the chat information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of this event. This meeting is being recorded and will be posted on the MnSCIMS website. To earn CME credit for today's presentation, please click on the link in the chat. And then due to the number of registrants for today's webinar, we've placed phone lines on mute to reduce audio feedback. However, we do welcome questions and we encourage audience participation using the Q&A function. But if you have any technical or logistical questions, we ask that you please submit those in the chat to Dan Kelly. We extend a huge thanks to all of those who work behind the scenes to make these webinars possible. Next slide, please. The title of today's presentation is Exercise and Wellness Behaviors After Spinal Cord Injury, an update on guidelines and scientific evidence. And the speakers for today's webinar are Dr. Ronald Reeves, Lisa Beck, Dr. Amanda Herrmann, and Dr. Kimberley Monden. First, Ron Reeves, MD, is a professor of physical medicine and rehabilitation at Mayo Clinic and a subspecialty certified spinal cord medicine specialist. He chairs the International Spinal Cord Society Education Committee and has previously held key leadership roles within ISCOS and Asia. His research centers on classification, management, and outcomes in traumatic and non-traumatic spinal cord injury. Lisa Beck is an associate professor at Mayo Clinic and a board-certified clinical nurse specialist specializing in spinal cord injury care, education, and research. She has authored key spinal cord injury resources and presented widely on spinal cord injury topics. She holds multiple national leadership roles in Asia and ASCIP. And internationally, she supports the WHO Rehab program and has provided spinal cord injury education in Mongolia. Dr. Amanda Herrmann is a research investigator in clinical neuroscience at the HealthPartners Institute Neuroscience Research Center in St. Paul, Minnesota, and serves as an adjunct assistant professor in the Department of Rehab Medicine at the University of Minnesota. Her primary career objective is to enhance the lives of those living with neurological conditions by advancing rehab research, particularly through the exploration of complementary and integrative health approaches to care. And finally, Dr. Kimberley Monden is an associate professor and licensed psychologist at the University of Minnesota, where she serves as director of the Division of Research and Innovation and vice chair of research in rehab medicine. Her work focuses on psychosocial adaptation after spinal cord injury, including resilience, injustice appraisals, and long-term quality of life. And she leads the SciPower Research Laboratory. Welcome, and thank you all for presenting. I will hand it over to you, Dr. Reeves.
Well, thanks so much for that really kind introduction. Um, so, just for orientation's sake, a couple of objectives here. I'm the opening act, but we'll over the course of the next 45 to 60 minutes review and critique the state of the science related to exercise and spinal cord injury, highlight the process of guideline development and the current guidelines and in the chat and discussion as time allows, hopefully maybe be able to touch on some of the policy and research considerations related to wellness. So from an introduction point of view, I'm just going to highlight key things related to mortality and cerebral or cardiovascular disease related to spinal cord injury. This sets the stage, of course, for exercise and wellness behaviors, but there's certainly other factors beyond just cardiovascular disease that we need to think about as well. As Dr. Hanks mentioned, I have some administrative roles with the International Spinal Cord Society and have had research funding from industry, but these things aren't related to presentations today. Just for orientation's sake to set the stage, we're talking today about spinal cord injury in a broad sense. Studies will include both traumatic and non-traumatic spinal cord injury. The majority of the research participants and most of the published studies are going to be traumatic spinal cord injury. And so shown here in the blue line is a population of people from Minnesota with traumatic spinal cord injury. All the other color lines are non-traumatic spinal cord injury. And for those populations, the diagnosis itself that's resulted in the spinal cord injury may be the most important predictor of survival overall. And as is obviously the case in the red line here, which is metastatic cancer, um, that clearly trumps everything else. We do have some existing literature that helps us understand mortality after spinal cord injury. And in this paper by Yu-Ying Chen and colleagues, they began to explore the relationship between body mass index and mortality. And overall, what they've demonstrated is this U-shaped relationship between BMI and survival or mortality, with both low body mass indices and high body mass indices conferring a degree of increased mortality risk. Now, within the overall understanding, there is an age-related component, and so for people who are younger, higher body mass index at a younger age is a greater risk. And for people who are older, very low body mass indices are at increased risk. Similarly, when one looks at gender, there are some differences. And so for men in particular, low body mass index may be a bigger risk factor. For women, there's a U-shaped curve noticed both at the extremes of body mass index. It is important to note in the sample, however, women are a very small part of the overall sample size in comparison to men. At the early years after traumatic spinal cord injury, low body mass index is a much greater risk than high, but as time goes on, increased BMI is a greater risk for mortality. Now, when looking at the causes of death in this sample, the number one cause of death, or the highest, largest percentage of people in this study, died as a result of respiratory diseases. Infective and parasitic diseases were the second most common cause. Cancer, third, and hypertension and ischemic heart disease accounted for only approximately 10% of the overall deaths in the sample. That, of course, is one of the diagnoses we think is perhaps most amenable to an exercise intervention. But of course, there's literature suggesting exercise and wellness affects a whole range of health outcomes beyond just cardiovascular outcomes. So way down at the bottom of the list here, I'll just highlight that endocrine and metabolic diseases. So again, something that may be influenced by exercise and wellness accounted for a relatively small percentage of the deaths in this sample looking at BMI. And when we look at overall trends of death over the last 50 plus years, one of the things we note is that um, several conditions, so endocrine, metabolic conditions, heart disease, and stroke, are all roughly twice as common after spinal cord injury than in the able-bodied population. Those are things that certainly are amenable to intervention with exercise and wellness. The good news is for all of those, fortunately, the overall mortality rate has been dropping over the last 50 to 60 years, but nonetheless is still twice the population average. One of the biggest predictors of risk as it relates to cardiovascular wellness is visceral adiposity. So this correlates very well with other risk factors. It can be reliably measured with a DEXA scan. And this is something that we'll probably want to be thinking about going forward rather than traditional skin fold or other sorts of measurements of cardiovascular and wellness risk. Now, there have been a few guidelines published in the last few years, and we'll talk more about these over the next couple of talks. But the first guideline was published by Martin Guinness and colleagues back in 2018, looking at fitness overall and also for cardiometabolic health. And this guideline recommended 20 minutes of exercise twice per week, as well as twice per week strength training, noting an increase of 30 minutes 3 times a week for cardiometabolic health. Now, Nash and colleagues have expanded that in their publication from 2022, suggesting slightly higher exercise levels and noting a variety of different ways to potentially acquire the recommended dose of exercise over the course of the week. Now, one question that often comes up is what is the best approach to exercise? And so is that arm crake ergometry? Is that lower extremity functional electrical stimulation? Depending on neurological level of injury, different types of exercise are more readily available than others. In this study by Farkas et al., they looked at arm crake ergometry in comparison to lower extremity FES and noted overall that arm crake ergometry definitely performed better in multiple indices as opposed to lower extremity FES exercise. But again, this will depend on, of course, the applicability of arm crake ergometry to the patient population. Now, one of the things we have noted, and this is from a study by Krause and colleagues published about 5 years ago now, is that fitness is a protective factor. And so what they've noticed when looking at their long-term patient population is those individuals in their population assessed with higher levels of fitness had a reduced risk for heart and blood vessel-related diseases in comparison to other potential risk factors. So fitness did not seem to affect the risk for sepsis or pneumonia or cancer, but clearly did affect cardiovascular disease. Now, the Consortium for Spinal Cord Medicine has published a guideline regarding cardiometabolic risk management after spinal cord injury. This is a peer-reviewed guideline that is readily available. And one of the things we'll want to think about and understand well is how is it that guidelines are developed? And so it is my pleasure to introduce my colleague, Lisa Beck, who has participated in guideline development. And I'm going to just continue sharing my screen and hand it over to Lisa for her presentation. And thank you for joining us, Lisa.
Oh, all right. All right. So I will log into my slides for everybody. Get everything on board. Let me share. And we'll get this process going. And thank you for the nice introduction and getting us started today. So So as Dr. Reeves did mention, I have a fairly good background in the process of guideline development, both here at Mayo Clinic within our nursing department years back, and now as part of the steering committee through the Paralyzed Veterans Association, helping in the development and identification of guidelines moving forward. So we will move on. I have no disclosures other than I have a job here at Mayo Clinic and that I do participate on the PVA steering committee, which is not a paid role, but a volunteered role. So importantly, why clinical practice guidelines? Why do we have them? Why do we need them? Why do we use them? So clinical practice guidelines really did not come about until the 1970s, and they were really based on expert opinion. We really didn't see the emergence of evidence-based medicine until the 1980s, and then that led us to more rigorous methodologies for guideline development, and then really emphasizing research over opinion. So clinical practice guidelines help improve patient outcomes. They standardize care, they optimize resource utilization, and the significance is we are integrating the best available evidence at the time of writing these. We're attempting to standardize care across different settings. We're keeping healthcare providers informed of advances in medical knowledge, and our practices can be monitored, for example, for quality improvement. So, who doesn't do a presentation anymore without just doing a really quick AI, what do you got for me? So I did a quick AI, what do you have for spinal cord injury clinical practice guidelines? And these are the top 5 that showed up on my search. And you can see this, the second and third ones are, actually it's third and fourth ones are really common in our rehabilitation practice of spinal cord injury that we utilize for establishing care or even just referencing our guidelines. So the Paralyzed Veterans of America has a comprehensive spinal cord injury care. And then the SCI project out of Canada focuses on rehab and long-term care. Both of these are evidence-based reviews. And they kind of work off each other a little bit, and I'll explain a little more. So Dr. Reeves did show you the Consortium of Spinal Cord Medicine cardiometabolic guideline that was developed and published in 2018. Just a step back of what is the Consortium of Spinal Cord Medicine? And this is really a group of 23 organizations that have been working on this project since 1995. And these organizations are a mixture of professional healthcare organizations and consumer organizations. And a member from each of these 23 organizations then becomes what we call our steering committee. And this group, we meet quarterly. Here's a quick access to the guidelines that are currently published via the PVA. The steering committee, again, we meet quarterly, and what we do is really identify what are the needs, where are the gaps. We identify topics. For example, we're looking into what are the new topics that we really feel like we don't have great information for our healthcare providers, primary care providers, that we can help organize some guidelines. And so we've got several of them. We also look at what guidelines are out there that may need updating. So quickly, soon to you will see outcomes after spinal cord injury. This is a guideline that's been updated significantly. That should be coming out early next year, as well as a new guideline, pain management and spinal cord injury care. And so those two should hopefully come out in the early part of 2026. And then an updated bladder management guideline is in the process. So these guidelines will take up to 12 to even 24 months for development, okay? So we will identify a topic and identify panel chair, co-chairs. And the panel chairs will then identify interdisciplinary panel experts to begin drafting an outline of what they would like to see in the guideline, looking for knowledge gaps, and really determine the key questions and search terms. And once those are determined, the key questions and search terms are then sent to our methodology team. And this is where the PVA is now working well, or we're working together with the SCI project, as they are our colleagues in methodology. So they will review the literature and grade the literature via the Pedro scale. Okay, so a little bit, what is the Pedro scale? It's really an 11 item scale, which this first item relates to the external validity of the research, and the other 10 items assess the internal validity of a clinical trial. So a higher score indicates a better study quality. Once the methodology has been rated and the literature information has been sent, goes back to the panel team, who then they kind of distribute who's going to write what sections of the draft. And then the draft will come together as a whole. And the team works on drafting what are the recommendations and supporting rationale based on that strength of evidence that was submitted to them. They will develop opinion-based recommendations that supports a narrative. And then they will also check their references for accuracy and completeness. And then finally, the panel does a grade, uses grade system to grade the recommendations that they've developed. And this is basically looking at the quality of the evidence as well as the strength of the recommendation. So that is the draft. Once the draft is pulled together, the draft then goes out to peer review. And this is typically 20 to 30 experts in the field that really look at content, usability. It doesn't make sense to them. And that will take a couple of months to get all of those reviews back together and processed. The reviewer recommendations goes back to the panel to incorporate any relevant changes. The document is then sent for professional editing, formatting, graphic design, and a final review happens by the panel. So again, it's a hefty lift from topic to a guideline that is complete and bound document. So what you're going to find in a full guideline, such as the ones through the PVA, you're going to find a recommendation statement, the strength of the evidence, and the panel opinion regarding the grading of the evidence, and then the rationale or justification. Why is this an important recommendation? So just a light humor on why are things important and why do we have good justification. So this, my 4-year-old granddaughter was at my house, had her pants in backwards, and I couldn't figure out why this was working for her until her justification was this. So in healthcare, we have a much more rigorous methodology to support what we do. But even stepping back, when we've as a steering committee have looked at some of the evidence behind our recommendations, and in spinal cord injury, we don't have a hefty number of persons in studies, so our ends are low. The strength of the research might be not as strong as we would like it, and maybe a lot of our recommendations are more still opinion-based. So we're going to look at that a little bit more thoroughly over the next year through the PDA guides and the steering committee. So we're focusing back to the physical activity guidelines for adults with spinal cord injury. This was initially started by the group out of Canada, a consensus panel of researchers in exercise physiology, exercise professionals, persons with lived experience, physician service providers. So again, it's an interdisciplinary team that looked at the evidence out in the literature. And the question was the minimal frequency and intensity, duration, and type of training needed to generate fitness benefits. They at the time could not generate or answer what would be a guideline to improve body composition because there wasn't enough research or evidence at that in 2011 to support that, or prior to 2011. So this group used a tool to look at the appraisal of their guideline, looking at the evidence that they wrote within their guideline, how strong is the evidence behind their suggested recommendations. And you've already seen a little bit about the guideline for persons with spinal cord injury. The frequency is 2 days a week for exercise and strength training. Aerobic training intensity is moderate to heavy. Aerobic training duration, 20 minutes. And so within the cardiometabolic guideline that PVA published in 2018, this clinical practice guideline is mirrored in the PVA guideline. So in 2018, we heard that the cardiometabolic health guidelines had been emerged. And again, the PVA guideline was published in 2018. So it's really what the evidence is at the time that you're reviewing and developing guidelines. So the 2018 added on to the cardiometabolic health benefits, at least 30 minutes of moderate to vigorous intensity aerobic exercise 3 times a week. So both guidelines really advised a lower frequency and duration of aerobic exercise than the amount recommended for the general population, as people with SCI are less active and more physically deconditioned than most able-bodied folks. So they also felt that persons with spinal cord injury can experience improvement in fitness and indices of cardiometabolic health in relative small doses of exercise, as you see here. So limitations of clinical practice guidelines, and you just probably heard a quick synopsis of this, but the state of the evidence and insufficient evidence at the time of developing guidelines. So we missed the cardiometabolic suggestions from the Canada folks to put into the cardiometabolic guidelines for the PVA. Again, it was timing. We don't have a lot of studies of physical activity in spinal cord injury. We don't have a lot of evidence that uses rigorous methodology in our research. And what happens when new information is published after the publication of the guideline? But not to say let's quit these. I think there's a really great benefit to guidelines. They provide a foundation for future research. It helps us understand where the gaps are. It's a great benchmark in physical activity monitoring and surveillance for persons with spinal cord injury, removes the barriers in recommending physical activity. So hopefully we can, that barrier could be dissuaded healthcare providers from recommending physical activity, so we can see more of it being suggested, and perhaps even universal coverage for physical activity expenses for persons with spinal cord injury. Wouldn't that be nice? And then finally, I think one of the other difficult things is dissemination of strategies. So once guidelines are published, how do we get that information out? And I think we struggle with that as well. We can publish certainly in scientific journals, trying to present at scientific meetings, making sure our depth and breadth is far enough and reach across different interdisciplinary, multidisciplinary organizations. We certainly could think of creating spinal cord specific modules in fitness, in professional certification courses, other things outside the box, quality projects, even support tools in the electronic health record for patients to disseminate, or for patients and for healthcare providers that might give us tools regarding guideline recommendations. or even a mobile app for persons with living with lived experience. I'm sorry. So just a quick bounce around on development of guidelines. Again, there's a lot that goes into these, and I'm just going to try and get myself back out of here. Okay, and not share anymore. And I'm done sharing, right?
Looks like it's still sharing.
It's not like I've not done this before. Why will it not let me out? There. Good.
Thank you, Lisa. All right. Well, thank you again for the introduction today. And thank you all for being here. So today I'm going to talk to you about the current evidence for strength training, aerobic exercise, and chronic inflammation after a spinal cord injury. And I have no disclosures to report. So in the last couple decades, there have been more and more systematic reviews and meta-analyses coming out looking at the effects of exercise in spinal cord injury. So the reviews tend to focus specifically on aerobic exercise, resistance or strength training, or a combination of those. Some focus on cardiometabolic factors, some have focused on neuropathic pain, or even the combination of using functional electrical stimulation along with exercise. And what we know from these reviews is that aerobic exercise improves cardiopulmonary factors as well as strength and cardiometabolic factors. So you can see several that were called out from the reviews here. Some improvements in things like VO2 peak and peak power output, strength, glucose metabolism, and body composition. When looking specifically at resistance or strength training, we do see improvements in some of those cardiopulmonary factors, as well as strength and lipid profile. There was also a couple of systematic reviews that focused on resistance training for both chronic and neuropathic pain, which showed improvements in this population as well. And of course, when we combine both aerobic and resistance training, as the guidelines suggest, we are seeing improvements in all of those factors, but the systematic reviews and meta-analyses specifically called out power output, muscle strength, and lipid profile as kind of the main factors that we're seeing improvements in spinal cord injury. Again, as I mentioned, there's some reviews that focus specifically on functional e-stim combined with exercise. And we see that there are a lot of cardiopulmonary and cardiometabolic improvements when combining e-stim. So here we see VO2 peak, peak power output, lipid profiles, body composition, and so forth. We also know that after a spinal cord injury, there are increased levels of systemic inflammatory cytokines. So there's proteins, some of these are listed here, so CRP, IL-6, and so on, that have been shown to be at higher levels in the blood when compared to a non-injured population. And the reason this is important is because chronic low-grade inflammation has been linked to both cardiovascular disease and respiratory disease, which are two of the leading causes of death in people with spinal cord injury. It's also been linked to metabolic dysfunction, pulmonary complications, impaired wound healing, and even obesity. So you can see that, this plays a critical role in the long-term health outcomes and functional decline after spinal cord injury. So there has been kind of one main systematic review that looked at the effects of exercise on inflammation in chronic spinal cord injury. And what we know from this review is that exercise can decrease the pro-inflammatory cytokines, and it also can promote the release of the anti-inflammatory cytokines. So the review kind of focused on three main studies. One incorporated a 10-week cycle program, another incorporated a 12-week arm cycle program, and the third was a 6-week body weight supported treadmill training program. And you can see that all of these studies showed that there were reductions in inflammation of these inflammatory biomarkers. However, the authors did note that the studies were limited by small sample sizes, lack of control groups, and short-term follow-up periods. So our research team was interested in looking at the effects of adaptive exercise on inflammation after spinal cord injury. So we applied and received funding from the Minnesota Office of Higher Education, the Spinal Cord Injury and Traumatic Brain Injury Research Grant Program, to conduct this study. And the results are currently, were just recently accepted in Topics in Spinal Cord Injury Rehabilitation Journal. And so for this study, we randomized patients into either an immediate start or a delayed start or waitlist control group. And so the immediate start group underwent a pre-treatment visit and then began the 12-week exercise program right away, and then underwent a post-treatment visit followed by a 12-week follow-up period and a final study visit. Whereas the delayed start group underwent a study visit followed by a 12-week delay, another study visit, and then they underwent the 12-week exercise program. So we essentially used the immediate start as our intervention group and that delayed period, so those visits around the delay period, as our control group for the analysis. We enrolled individuals with both a traumatic and non-traumatic injury into the study. We included individuals ages 18 to 70 who had a spinal cord injury or diagnosis more than 6 months prior. And really, we didn't specify by kind of injury level for this study. We really just wanted people to have an ability to complete our 1 rep max chest press, which is what we used for the strength test, and the arm cycle ergometer test. We conducted a 6-minute test for the cardiovascular fitness test. And so they really just had to have some shoulder flexion and elbow extension to kind of be able to do those tests. For exclusion, you can see kind of the medical reasons that we excluded patients listed here. So for the study, we screened 38 individuals total, and 24 of them consented to be part of the study. We did have 4 people who withdrew after randomization, but prior to starting the exercise intervention. And you can see kind of the reasons here were loss to follow-up, and a couple who were randomized to the delayed start group and did not want to wait to begin exercise, and one with medical issues. We had 20 who began the exercise program, and unfortunately 6 who withdrew. So we only had 14 who completed the full study. And also the reasons for withdrawal after starting exercise are also listed here. So we had some loss to follow-up, injuries, illnesses, etc. So the exercise intervention was led by our certified exercise physiologists at the HealthPartners Neuroscience Center. So individuals participated in our NeuroWell program, which consisted of small group exercise in our rehabilitation gym space. Individuals exercised for 3 times per week for 12 weeks for 60 minutes per session. And exercise included a combination of aerobic exercise or endurance training, resistance or strength training, and neuromotor activities. And our exercise physiologists really aim to adapt the program to each person's functional abilities, increasing difficulty over time. And the program was personalized to accommodate the individual's fitness levels and goals. So for the results, the participants' mean age was 53, primarily white males who participated in the study, a slightly more traumatic spinal cord than non-traumatic, and mean time from injury or diagnosis to enrollment was 10 months. You can also see here that we had kind of a range of both ASIA impairment and neurologic level of injury. So we didn't have any ASIA Bs, but we had ASIA As, Cs, and Ds who participated, and several unknown. As you're probably aware, the ASIA exam is not as commonly performed in non-traumatic SCI. For neurologic level of injury, we primarily had participants with cervical or thoracic level. And then for ambulatory status, we asked patients to self-report whether they were ambulatory, used a manual or power wheelchair, or some combination of those. So you can see we had a wide range and variety there. And so between our two groups, we didn't have any significant differences in demographics except for in regards to neurologic level of injury, where we did have more cervical level injury participants in the immediate start and more thoracic level injury participants in the delayed start group. So the results of the study showed that at baseline, the levels of inflammatory biomarkers, strength, and cardiovascular fitness were similar between groups, which is what we would have wanted to see. We did see in the intervention arm compared to that control or that delay period in the delayed start group, we saw that the intervention arm showed a 59% greater reduction in IL-6 compared to the control group, but unfortunately, the other biomarkers were not significantly different between our groups. We also found an improvement in strength. So that was that 1 rep max chest press. Unfortunately, no significant changes in cardiovascular fitness, which was that 6-minute cycle ergometer test between our groups. Only 4, which was 7% of all of the reported adverse events, were considered definitely or probably related to treatment. So we did ask participants to let us know if they had any injuries, illnesses, or major life events, which could cause stress, and whether or not they were related to the intervention or not. So we had quite a few AEs, but again, not that many that were related to the intervention. We did have some serious adverse events, 7 total, and these were hospitalizations while participants were in the study. But of these, all were considered to be unlikely or not related to treatment, primarily consisting of like hospitalization for breathing difficulties or infection or skin problems or injury outside of the study. Participants completed 78% of sessions, and we compared, we looked to see if that was associated with our results, and statistically was not related to our results. So as you can see, we had some mixed results. We believe this was likely due to our limited or small sample size with only 14 study completers. We also had quite a heterogeneous population, including both traumatic and non-traumatic in the study, all abilities and ranges of injury or levels of injury. We also had lot of barriers to participation in the study and completion of the study. So people who declined participation in the study reported things like transportation issues, distance, scheduling issues, and the delayed start group as barriers. Most participant withdrawals were due to injuries outside of the study or scheduling conflicts, which were largely unavoidable. And the PI or study withdrawals were due to primarily to loss to follow-up or missed appointments or acute illness preventing exercise participation. We did, however, show that some evidence that adaptive exercise could reduce inflammation after spinal cord injury, and the low incidence of intervention-related AEs and absence of intervention-related SAEs support the safety and feasibility of this program. And future studies, of course, could look at larger stratified samples and longer follow-up periods. So I am going to go ahead and pass it off to Dr. Monden, who is going to talk about the psychological benefits of exercise.
Thank you, Amanda.
Yeah, give me 1 second to get out of here. Okay. There we go. All right.
All right. So I'll be talking, as Amanda said, about the psychosocial benefits of exercise after spinal cord injury and talking about some of the evidence that we found in our module study that was actually part of our model systems cycle this round. So I don't have any disclosures other than the fact that I guess I am funded by NIDLR as project director of the SCIMS, which funded the project that I'll be talking about today. So as we know, physical inactivity is a critical public health issue for not only the general population, but especially for people with spinal cord injury. So individuals with SCI face significant health challenges, including cardiometabolic risk and obesity. And despite this, we know that up to 50% of individuals with SCI actually report no leisure time physical activity. So while research suggests in the general population and some research in the SCI population that physical activity can have psychosocial benefits like a reduction in depression symptoms, there is limited real-world evidence on overall psychosocial impact of physical activity and of specifically meeting the spinal cord injury physical activity guidelines. So the purpose of our study was to conduct a multi-center study across 5 model system centers as well as non-SCIMS participants to determine if adherence to the SCI-specific cardiorespiratory fitness guidelines, and I'll talk about that in the next slide, is associated with improved self-perceived health status and other psychosocial outcomes while evaluating for the competing influence of income. So, and other variables. So, as I mentioned, this was a multi-center observational study across 5 SCI model system centers in addition to non-SCIMS participants. Our sample included 361 adults with traumatic SCI who were at least 1 year post-injury. And we measured physical activity with the Leisure Time Physical Activity Scale, which measures how much moderate to vigorous activity people are reporting in the last 7 days. And then our outcomes were number of hospitalizations in the previous 12 months, and that was our primary outcome. And our secondary outcomes were perceived health, resilience, depressive symptoms, quality of life, and social integration. And so to conduct our analysis, we grouped participants by activity level and ended up with 3 groups. So there was a no activity group, a some activity group, and a MET guidelines group. So about those guidelines, as Lisa Beck mentioned earlier, these are the Spinal Cord Injury International Scientific Exercise Guidelines by Kathleen Martin-Guinness et al. From the University of British Columbia, Okanagan. And so we were focused on the cardiorespiratory fitness guidelines, which say that you should get 20 minutes of moderate to vigorous aerobic exercise twice a week, in addition to 3 sets of strength training twice a week. So we did not focus on that guideline further below the cardiometabolic, which is 30 minutes 3 times a week or 90 minutes. So who was in our study? So our final cohort, once we went through the data and took out people who were missing variables, we analyzed a cohort of 342 participants. So demographic factors were statistically similar across all 3 physical activity groups. And while demographics were similar, injury characteristics differed significantly. So the inactive group had been injured longer, so 16 years versus 11 years, and were more likely to use power wheelchairs. So this suggests that the no activity group isn't just being inactive maybe by choice, but they are on average living with their injuries longer and have higher levels of mobility impairment, which may represent more barriers to exercise. A key finding in our study was that 26% of our participants met the cardiorespiratory fitness physical activity guideline, and that's more than double the 12% reported by a previous study conducted in the province of Quebec in Canada. Additionally, our inactivity rate was 28%, which was lower than the 44% also found in that Canadian study. And there's other studies that have found inactivity rates of up to 50% in the spinal cord injury population. So we had a relatively active population in this study, or sample in this study. So as far as what we found, and I'm keeping my eye on the time here, so I apologize for rushing. We found that individuals meeting the guidelines were almost 3 times more likely to report better perceived health compared to the inactive group. And adherence to the guidelines was also significantly associated with higher resilience scores. So this confirms that an active lifestyle enhances internal well-being and adaptive capacity. Resilience, essentially. Our next finding was really unexpected to us and a bit of a paradox. So contrary to our hypothesis that participants who met the guidelines had nearly a 2 times greater risk of hospitalization compared to the inactive group. So we hypothesized that they would have less hospitalizations. They actually had more hospitalizations if they met the guidelines. So we spent a lot of time talking about why this might be. One reason we talked about among the team was that healthcare providers may be successfully encouraging individuals with greater medical risks to exercise. So we're not sure how to fully explain these findings. It was unexpected to us, but I think it's still important to tell people what we found, even if it didn't confirm our hypothesis, because that's science. Finding 3 was about our psychosocial outcomes, so all of those secondary outcomes. So after adjusting for covariates, physical activity was not significantly associated with any of our psychosocial outcomes, including depression, pain interference, quality of life, and social integration. So again, not what we were hoping to find. Some potential explanations for these findings are that the dose, so maybe the SCI guidelines of 40 minutes per week may be too low to impact these psychosocial outcomes. Also, the leisure time physical activity questionnaire doesn't ask participants what type of physical activity they were engaging in. And there is evidence to show that the type of physical activity, so mindfulness-based, like something like Pilates, might matter more than just like duration of physical activity. So are you getting more enjoyment or more benefit out of some types of activities than other types of activities? And then, as I alluded to, we found this association with income, and that's really kind of what really washed out most of the effects in our psychosocial outcomes. So the most powerful predictor of reduced pain, lower depression, and better quality of life was household income, not physical activity or not meeting the guidelines. So higher income groups reported significantly fewer depressive symptoms. For social integration, the strongest predictor of community involvement or social integration was being in the higher income bracket, the middle or higher income bracket. And so one of our, explanations for this finding is that financial stability provides resources like adaptive equipment, transport, care, all of those things, access essentially, that might buffer against the stress or some of the secondary complications associated with spinal cord injury. So what can we take away from this? We know that exercise works, at least for self-perceived health perception. People feel better when they exercise, and they also feel more resilient. As far as the association with other psychosocial outcomes, so depression, quality of life, it's less clear and may depend more on the type or dose of activity. We found that income is really critical. So socioeconomic status was exerting a competing and often stronger influence on mental health and quality of life than exercise alone. And so what does this mean? I think moving forward, interventions are going to have to integrate not only physical activity promotion, but also work to address these social determinants of health, like financial resources and access. I apologize that that was so quick, but I wanted to at least leave a few minutes for questions. So Angie, I guess I will hand it over to you.
Wonderful. Thank you all for great presentations. So we will invite folks to type in questions in the Q&A box, and I can monitor those. We might have time for one, maybe two.
And I have to do a shameless plug. I just created a LinkedIn page for our Model Systems Center. It's the bottom link there. I couldn't get the QR code to work, so apologies. But if you go on LinkedIn and you search for Minnesota Regional Spinal Cord Injury Model Systems, we're there now. So please connect or follow us, and we'll be sure to put the link up to the recording for this as well.
I have a question, perhaps in a 1-minute question here. So with the rise of the popularity of like GLP-1 medications, I wonder if you all have seen any kind of research around using GLPs, especially this made me think of on your slide, Dr. Reeves, the visceral adiposity slide. I'm just wondering if using GLP-1s in this population coupled with physical activity would enhance even more, or your thoughts are around that.
I think that's a great question, and I know our colleagues at the Bronx VA have begun to explore that and have published a bit about that, and I'm pretty sure Gary Farkas and Mark Nash are also exploring that. Most of the data thus far is very small sample sizes and select populations, but certainly if one thinks about especially circumstances where access to equipment, resources, circumstances where muscle function is quite limited. So higher level injuries where it can be very difficult to attain a cardiovascular workload. There may be very important roles for the GLP-1 medications. The side effects in terms of the bowel side effects and things obviously will pose a challenge.
Sure.
Especially if it causes lots of problems with incontinence, that may not be super joy bringing for folks. But a great question. And I think in the next 5 years, we'll probably have a lot more data.
Sure. Thank you. I know we don't have much time left, so people are probably thinking of their questions or furiously typing. So I apologize if we haven't got to your questions, but do feel free to reach out to anybody on this panel directly to follow up regarding any questions you may have now or later. Again, this recording will be on the YouTube channel for our SCIMS program. And as a reminder, see the chat for information on how to obtain your CME credit for attending today's webinar. Once you log off, you're going to get a brief 3-question survey that pops up. We would really appreciate your feedback. And we thank you all for your time. Have a great rest of your day.
Thank you.